thank you everyone for staying for, I guess, the whole entire day and lasting through the dinner session. And we've got dessert on the tables for those that are in the room with us. While the panel makes its way onto the stage, I'll introduce, I guess, the second part of this session. So tonight, we've started off with some wonderful presentations and we're moving into a very lively discussion to pick up where the presenters have left off. So, to begin with, we've had, just to introduce myself, I'm Sarah Chu. I'm a Brisbane-based GP, travel doctor and an Immunisation Coalition member. We've got two topics to cover, and I want to apologise once again to Paul Van Binder because we're going to swing the needle back to maternal vaccination and infant immunisations, learnings and lessons. And when I had a quick look this morning on NNDSS with the data, we were up to about 67,500 notifications for RSV year to date, and about half of them were in those that were under the age of 5. So I thought it was very fitting to start off with maternal and infant vaccinations and go to the panel with those questions, but we will end up where it's important with adults as well, because that's the bulk of our practice. We've got an ageing population. I'm not getting any younger, and I don't think anyone else in this population is, so one day that will be very, very poignant for all of us. So the esteemed panel members, which you see up here, most of them probably don't need an introduction, but I'll whiz you through them all the same. To my right, we've got Rod Pearce. He's an Adelaide-based GP who's got the difficulty of trying to make these sessions and balance his work, and also is the chair of the Immunisation Coalition. We've got Professor Peter Richmond, who I'm going to direct some very difficult questions to as well. He's probably a consultant paediatric immunologist who most of you know very, very well, based out of Perth Children's Hospital. Does a lot of work, and I've just recently told him, I've been listening to your podcast, and in my mind you're a bit of a star, and I'm a bit celebrity struck. So we've got a lot of very interesting questions coming his way, and I've primed him on that. We've also got Sonia here with the lovely glasses here, waving her hand. She's one of Victoria's first nurse practitioners in the field of immunisation. So it's really going to be fantastic hearing her take on things, bringing her teaching and research links from the Monash University and the Murdoch Children's Research Institute to us tonight. And we've got Cassie over here as well, Cassie Dorr, a lecturer in midwifery at the University of South Australia. So we've got a variety of questions to give to our panel members. So some of them, I thought I'd kickstart off with a couple of questions. Later on we'll open it to the ones that are online as well as to members of the audience here. Don't forget to speak into the microphone, and I might even repeat them if they don't come out clearly so our members that are listening online won't miss out on the questions. As promised, I have a difficult one to start off with for Peter. Now, Hannah's already set the stage. A lot of the presentations, even what Ushma mentioned, the epidemiology is very different. The seasonality varies depending where you are in Australia, whether you're further down south, further up north. The funding that's available that varies state to state, territory to territory. So, Peter, as much as it would be very easy for me as a GP to say vaccinate all the mothers 28 to 36 weeks, or maybe all newborns when they're born at the hospital, we can see from the data tonight that maybe that is not the best approach. That's not going to give the best protection. So I'd like you to make a couple of comments, or as many as you'd like. What considerations might we need to take into account with respect to the timing of nirsevimab to optimise infant protection, given that there's so many considerations?
Okay, so thank you for that very easy Dorothy Dixer question that you've given me. So I'd just like to say a couple of things. Full disclosure, I have advised a number of vaccine manufacturers and monoclonal antibody manufacturers on RSV because I'm very passionate, and my biggest disclosure is I've been a paediatrician for 35 years looking after babies with RSV, and so to have something to prevent that is fantastic. I think the first thing to say is that babies having antibodies against RSV will protect them against severe disease, and so whatever way we can do that, we should do that. I think that Australia has funded a year-round maternal vaccination program, similar to the UK, but dissimilar to Argentina that we heard about today, that had a seasonal maternal vaccination campaign, and that's in fact how the maternal vaccination studies initially were conceived, that they were sort of seasonal vaccinations. It's not dissimilar to flu. So I think the first thing to say is that vaccine is being provided free to all the states and providers, so we should utilise that. However, if you have not received a maternal vaccination, then you should definitely have a nirsevimab, a monoclonal antibody, and the best protection you will get from a monoclonal antibody will be if it's delivered immediately before RSV is circulating in your particular area. So if you're in Darwin, that could be all year round, so then it's as soon as you're born. But if you're in Western Australia or Adelaide, then maybe it would be just before winter starts, because that's when RSV is circulating. And WA is yet to start its RSV season. I was on call last week and we only had one child in the hospital with RSV, so I know it's not around. So this would be the good time to vaccinate you if your mother hasn't been vaccinated recently, or your mother's been vaccinated and you were born recently. But if your mother was vaccinated 8 months ago, then probably those maternal antibodies are waning quite significantly. So if you're in a jurisdiction where you're able to provide a monoclonal antibody, then I would definitely be offering it. A more difficult question, I think, is how do you counsel somebody who is pregnant and says, should I get it now or should my baby get it when they're born? And I had a registrar who came up to me today and I said, oh, she was obviously quite pregnant, was about to go on maternity leave, and I said, oh, so have you had your maternal vaccine yet? Thinking, yes, you know, she was a good registrar, definitely she'll be there. No, I've decided to get my baby, give my baby nirsevimab when they're born in a couple of weeks' time. And I went, okay, that's a reasonable decision. So the question is, what do parents prefer? And I think for health providers, we should be able to give people a choice. And I think in WA, certainly that has been the option, is that it's a choice between maternal vaccination and nirsevimab. We have 2 highly efficacious vaccinations that will provide you for protection that looks at least 6 months. And you know, from that talk today, and I think this is a really important question, is, you know, do we get 9 months protection from maternal vaccination or monoclonal antibodies? I think we get more protection than that from future complications of RSV in early infancy. So we will definitely see an ongoing impact. But I think that's an important thing to consider. Some states that's not available. So some states you can only get nirsevimab if you haven't, your mother hasn't had vaccination and you haven't had it as a newborn, then maybe you've missed out unless you're at high-risk disease. I think that's probably not the best thing to do. I'd be advising that you should still be able to have a catch-up monoclonal antibody as soon as possible in relation to the RSV season. The question is, can we make that cost effective? You know, optimal protection is probably a combination of a maternal vaccination that gives you broad antibodies against a wide range of epitopes, and a very directed monoclonal antibody that gives you protection because it protects against one particular strain. So that's probably ideal, but we probably can't afford that. So then we have to decide, what can we deliver? And as we've said, a vaccine in the fridge doesn't protect you, vaccination does, or immunisation if it's a monoclonal antibody, and maybe we shouldn't be so cute about trying to call them all immunisations. That may cause some confusions. I've already had 2 calls last week about a GP saying, I've given an RSV vaccine to the baby. What should I do? Do they still get the monoclonal antibody? The answer is yes, and actually they probably do provide. It seems to be safe in the ones that we've had reported, but I think confusion is everything. And I think for me it's all about coverage. Impact is effectiveness times coverage. So that's what we should be aiming for. Whichever way we feel, our population, we can deliver the greatest coverage to provide the best protection over the time when RSV is circulating. So I guess the answer is, it depends.
It definitely does. And I wonder what your registrar would have chosen if there was a third choice where she could privately, where you're not choosing between maternal and nirsevimab, where you have a choice of a combination where you're not restricted by state and territory funding. What if you had private choices, privately self-funding?
Well, exactly. I mean, that would be not an unreasonable choice. And, you know, depending on when you've been born, then that actually might well be the actual preferred approach. So I think, you know, this is still a space. I think Australia has always been very proud of its national immunisation program delivering health benefits to a population. And I think this artificial separation of monoclonal antibodies and vaccines hopefully will be corrected within due time. But then that's a really difficult question. And I think we need to learn as much as possible that we can from this year about what works and how long does it work for and what are the benefits. And there are some additional benefits of vaccinating mothers. You improve her immunity, you may provide additional protection from breast milk, and you may provide better protection if there is some variants that are circulating that aren't as well covered by a monoclonal antibody. So there are comparisons, but I think Ushma showed that having a single monoclonal antibody immunisation program worked very well, and that's been shown in a lot of European countries. But that's not what we have in Australia now, so I think we really have to say, you know, what can we deliver for the patients in front of us? What is their choice? And they're both safe, they're both effective, then, you know, we can have that discussion. And I understand that sometimes it's easier. Most people will just say, well, what do you think, doctor? You know, what would you do? And I would base it on what time of year it is, when the mum's due for having the pregnancy, and what's the mother's preference, you know, and I think they're the sorts of questions we should have. And the other question is, you know, second pregnancy coming around, you know, do you give another vaccination? That recommendation is still to be made. It's probably going to be yes, and depending on the time frame, we know that these RSV vaccines look as though they last a while. So I think there's a few options that we can consider, and certainly for the next pregnancy, again, that might be a different choice.
Mm. You mentioned a really good point about coverage, and Ushma has also presented the data about the average coverage being about 79% in the birth cohort. Rod, I want to throw to you, I guess she also showed that in our Year 1 First Nations cohort it was about 61%, but shockingly in the Year 2 it dropped down to 30% for those with medical risk factors and our First Nations patients as well. Given that the bulk of the vaccinations seem to occur in general practice, what general practice systems can help us to identify those infants whose mothers may not have received the maternal vaccinations or who might have missed out in hospitals? Any tips?
I think Peter's raised the question about if you make it too selective and too specific, that will end up with people getting confused, maybe not actually doing it. So as much as it'd be nice to say we make sure everyone gets it as close to the season, we found with when you have a choice with vaccines and consider it and all that sort of stuff, then we don't get high uptake. So we've talked before about hepatitis B program. When it was optional or for high-risk people, we ended up with sort of less than 10%. But when it was everybody and universal, it becomes easier. So I'm, as much as I can see the benefit of actually saying you have it close as you can to the season, I think the way our system works, the fact that the Commonwealth is funding and talking to GPs, states have got getting different information, so rather than confuse it, I think you make sure that it's available to everyone and you say this is part of the time. So I think if we try seasonal, we're going to lose numbers. If we try to target it and give too many choices, it's going to be diluted and there's going to be even more confusion and people are going to fall through the gap. So as much as I see the benefit and targeting it to a specific season, I think we're better off to go for, let's get 60% better than getting 20% exactly on time. I think it's better to get 60%. So I'd say make it for everyone and make the rules clear and simple, because Australia's done well by having a vaccine program that says 2, 4, 6, 12, 18 months and school. Everyone knows that, and then you work out which vaccines. People know at a certain time it's got to be that. But I think there's even 3 recommendations, different vaccines at different times during pregnancy, which is even creating some. And at a recent meeting we got asked, is it all right to give it the week before they deliver? And it's like, no, I don't think for pregnant women that's going to be much use to them or the baby. So I think it's adding to the confusion when there's too many choices, as much as you give credit to the clinicians. I think some of the rules, simplicity, I think.
Absolutely. So I guess to anybody from the federal government who's listening, we're really asking you to maybe put it on the NIP to simplify things. But I guess that will have a potential benefit of making things very uniform, accepted. There's riding on the success of the cartels of the 90-95% vaccination rates. Is there also the potential, I guess, for any downsides by putting a monoclonal antibody under a national immunisation program banner? Anybody. I'm not going to pick on you. What are the potential benefits and downsides of putting a monoclonal antibody under the National Immunisation Program? For us clinicians, obviously it would be it will simplify things and make parents, I guess, it's just a lot easier because they'll know this is when you get it and this is the standard.
Yeah, I think certainly it'll make it a lot easier for families to, as you say, follow the program. But I think, as Peter said, because of the difference in RSV, in the different states, it kind of does make sense that there would be some state variations as well. So I think it's tricky. I think for families it'll be easier, but I think, in terms of protection, maybe not so much.
I suspect it'll end up something in between what would be ideal and what actually is achievable, and something in between.
I mean, what I would add to that is that if we're getting 60% coverage for our maternal vaccination program, we want to do better, but in the meantime, why don't we catch up that other 40% with something that is also effective?
Mm-hmm. Sonia, now there's been a lot of, we were just chatting even before dinner, last week was RSV Awareness Week, so there was probably a webinar or some meeting every single night of the week on RSV. So we've been talking a lot, and there's been a lot of information about what to do. Could you speak to some of the common vaccine administration errors that have occurred? Because all of us here, we're mostly of a growth mindset. Mistakes are how we learn. So please share some of those experiences. So hopefully they're not repeated as often.
Yes. So I think in an ideal world, we wouldn't be making any errors. And I think we're probably speaking to the, converted here, because everybody here is interested in RSV, and it's probably absolutely across the program. I think the gap is the knowledge maybe more broadly than that in the community. I certainly think that errors weren't unexpected, because we had seen the American program in 2023. There were errors where infants received the maternal vaccine and pregnant women received the vaccine for older adults. And unfortunately, we're seeing the same thing here as well in Australia. So we've already had reports of infants having received the maternal vaccine. So in fact, I recently consulted a 4-month-old infant who had received the maternal vaccination. They were one of 2 infants from the same practice. So that's clearly a deficit of knowledge in the practice, not an isolated incident. So I spent a long time with that family actually talking about RSV, the disease, because they actually didn't even know much about it, and had a long discussion about, RSV, the monoclonal antibody, and went on for about 30 minutes. They went and had a think about it, and then they came back and had the nirsevimab, which is terrific. And we've had errors as well where the pregnant mum has received the incorrect vaccine, like a RSV, and so in that case, you wouldn't obviously give any further doses of RSV to the pregnant woman. We've had instances where pregnant women have had the vaccine much earlier than 28 weeks as well. So again, you wouldn't repeat an RSV vaccine for her, but you may want to consider nirsevimab for the infant. And I think one of the great things that we do have here in Australia is the National Centre for Immunisation Research and Surveillance Group, who've actually come up with a fact sheet on clinical guidance for RSV immunisation errors. I think that's really well planned, I think, because I think we'd like to think that errors don't occur, but unfortunately they do. And I think one of the things I often tell people is that to err is human, but it's how you handle the error. And this particular family, this 4-month-old infant, was really annoyed that the practice didn't sort of acknowledge the error or apologise. And I think their concern was mainly around what is the practice going to do to make sure it doesn't happen for other infants as well. So, as I said, I think we really do need to get the messaging out about RSV. I certainly think that providers need to be familiar with the different resources, especially when there are state variations. That's why I think a national program would be much easier. But because of the state variations, people have to be really across, the RSV programs, in their state. So.
It's very easy to make those mistakes, whether it's even influenza. I remember getting a phone call, a child has received a fluad quad under the age of 5, which fortunately, in this situation, we mentioned that overseas some countries actually choose that as their preferred vaccine. But I think it's important to share where some of the pitfalls are so that we don't make that again. And it really resonates with me what you mentioned about the family being very understanding and hoping that it doesn't happen to somebody else. I often find with the open disclosure that's really what they're looking for, that it doesn't occur again, but they're very understanding to work together.
And one of the errors I did leave out was errors of omission. So that's also not having the conversation with families about RSV, and then that infant, going and getting RSV. And again, we've seen it with meningococcal. Families who end up in hospital with meningococcal disease get really angry when they weren't informed that there was a vaccine that could have prevented it. So again, it may not just be about getting a vaccine in an arm or a monoclonal antibody into an arm, but you have to at least be having a conversation with families about RSV.
And that's what, I guess that's what formed part of that informed consent, that there is that vaccine decision-making choice either way that's given to the patient. There's also, I guess, earlier administration than what would be ideal, so maternal vaccination given before 28 weeks. Do you want to touch on that while I guess we've got you on the floor?
Yeah, I mean, the product information, of course, for Brisbane is actually from 24 weeks. It's just that the national program's been rolled out from 28. So I certainly think that if a pregnant woman received the vaccine from 24 weeks, that would be absolutely fine. You could say with confidence that the infant will be protected. It's when it's given earlier than 24 weeks that, you know, it's probably not as clear. So I think then you could really talk to the family about considering nirsevimab.
I think it's one area when we're teaching registrars, especially in my practice, we specify brands very deliberately. So as much as there's a push to use generic names, I find that there's a lot more room for error, but using brand names can help to reduce that chance from happening. Cassie on our stage is actually has a lot of experience in midwifery, and I'd like to pick your brains. Given that Brisbane has been rolled out in, I guess, our maternal vaccination program, about a 60% uptake rate. Are there any differences from what you're sort of feeling with first-time mothers compared to those that have been multiples, for example?
Yeah, thank you. I think from my experience, women are generally very open to learning about ways to protect themselves and their babies, which lends itself to having some really lovely and valuable conversations in the lead up to the time where they're going to be eligible for this. First, I don't want to generalise, but from what I find, first-time mothers are often a little more cautious, and understandably so, in having questions. And so enabling those spaces to have those productive conversations, answer questions, unpack assumptions can be really valuable at that time. Generally very on board with understanding all the different things and strategies they can be doing along the way to protect their babies. Women in subsequent pregnancies often, not always, but often a little more relaxed and accepting, especially when they've had vaccinations in previous pregnancies as well. I think there is a real value in integrating in these recommendations within antenatal care. As we've mentioned, I think that gives people a sense of clarity, coherence, and a lot of trust in what those recommendations are.
Thank you. One of the things we saw was that with subsequent pregnancies, it meant that there's older children that can potentially bring this back and put the newborn at increased risk. But it also means if there's one sick child, the parents off work, then they might not be able to take the others onto their extracurricular activities, missing school. So although there was that $7 million that was saved, the $11 million in terms of expense, childcare, the last time I paid was about $120, $30 a day. Add to that the parents' inability to work, two miserable people at home. People remember, I don't know, maybe drinking, not just necessarily coffee to get through their day while you're stuck at home with kids at home during COVID years, but I don't think people really want a sick child at home. So there's a lot of those considerations. The other thing we were talking at our table was that it's not just preventing that, but also the asthma and the recurrent wheezy episodes in the future that we're hoping to look at the data coming through. Just while I've got you there, pregnancy, a lot of the studies with RSV vaccines were in people over the age of 18. We've obviously got a cohort of teen pregnant mothers. Any concerns with under 18 vaccinating pregnant mothers that are under the age of 18?
Look, my understanding at this point, as you've said, the clinical trials have been with participants over the age of 18 or greater 2, but no safety concerns have been raised that would indicate that there is any concern in that, and certainly there would be, it would be deemed quite valuable and important to be having that same conversation with women and adolescent mothers, and in fact highly important in many instances, in the remit of it being within the scope of their care management and their wider healthcare team.
Thank you. Now, I know we won't focus exclusively on children and mums, but, you know, with Paul standing right in front of, or sitting right in front of me, we'll move on maybe to the adults as well too and talk about the older age group. My mum will be turning 70 very soon. In fact, that was my birthday present to her. I thought rather than buying some stuff she does not need and does not want, I gave her the RSV vaccine privately. So there's some alternative funding. Rod was saying there's a lot of DVA patients as well that can get it on a private script. So apart from private health insurance, asking other family members to fund it as a novel birthday idea, I guess there's a lot of funding for our older adults as well, since it's not on the NIP yet. Very positive. So how much do we need to talk about RSV with our patients? We've been talking about it non-stop, obviously, for a long, long while. Any takers? How much do people really know about RSV?
So I don't think there is a lot of knowledge about RSV, particularly in older adults. My aunt in Queensland, 70, has emphysema, didn't know anything about RSV, ended up in hospital with RSV. When we tried to call her to speak, she couldn't even speak on the phone. She was in hospital for about 4 days with oxygen therapy. And again, she was really annoyed that there was a vaccine available that she wasn't aware of that could have prevented that illness. So that was last year, so I guess who's getting RSV vaccine this year. But there is a real lack of knowledge, I think, in older adults, and even those with underlying respiratory problems.
Paul, the reason that there's not much talk about old people and vaccinations, I think it's more complicated. So that's why easy fix is to get the paediatricians and fix the children, and then it gets really complicated. I always think in the elderly, if you just consider you had a chance to talk to Pauline Hanson, Gay Waterhouse or Malcolm Turnbull about their vaccines, you'd have a different concept of how you'd approach it, yet they're all the same age. So it's simple if you take someone's age and say, this is the age where you need a vaccine, but if you take their lifetime experience and talking about their understandings, what they would like, and maybe what vaccines they've had, it actually makes the whole conversation more complicated. So I think that's why we haven't solved it, and maybe that's why people are avoiding it. But Peter and I were talking before about, do old people need to know that it's a virus that they can do something about? And I guess GPs are talking about it because we actually can do something about it. A lot of the time when we can't do anything about it, it's just another virus. But I think now we've got testing, we can do rats, and that's got its own issue because people don't report it, but you could have COVID needs treatment, you can have flu needs treatment, RSV, could have a vaccine, could spread it. So I think there's a chance to talk about it. Maybe in children we talk about bronchiolitis, and I think people understand that more, and it makes it easier to say, look, you can prevent bronchiolitis, maybe prevent asthma, and maybe Peter might want to talk about that. So, but I think in adults, here's a vaccine that will actually make a difference. We can actually do something about RSV. They don't necessarily need to know all the specifics about what it does, but I think it's important now, test everything, test it properly, do a PCR. If you've got something you can treat it, know what it is, and then actually deal with it and put it into context rather than just say, oh, it's just another virus. I think the environment's changed.
Yeah. I think just to add to that, all that data that we were seeing tonight is about adults getting admitted to hospital. And so that's really, if that's your prevention aim, then making sure you're targeting people who have comorbidities, and particularly those who have multiple comorbidities, or everyone in a care facility needs to have an RSV vaccine. That will keep them out of hospital. But I think I would like to sort of bring up Paul's point about actually healthy ageing. So, people will do lots of things. They'll eat a lot of kale because it's good for their microbiome. They will take probiotics. Well, look, an RSV vaccine will stop you getting RSV. So, and you probably only need to have it every 3 to 4 years. So I just think we need to change the sort of language around what we're doing. And it's about preventing deaths and hospitalisations, but it's actually about staying healthy. And, one thing I've learnt by looking after babies with RSV is the mum or dad usually have it, and they're saying, why can't I have a vaccine for this? Well, I think older people, and particularly if they have grandchildren, then this is something you don't want to have that you're going to give to your grandchildren, so why don't you get a vaccine? And that's been very successful for pertussis. And I think if we get it on the National Immunisation Program, it then becomes accepted that this is something for everyone from age 70. But if you're 60, 65 and you want to stay healthy and you're travelling overseas or you've got grandkids, then why wouldn't you have it?
Should we make it like the pertussis program used to be with the cocooning strategy and market it that way? I guess there's the evidence and there's the acceptability. There's so many things. Please comment.
The only other added perspective I was going to add was around, I know it was touched on before, about a lot of my work at the moment is with midwifery students and helping them understand the role that they're going to play in disease prevention as well, and advocacy, and understanding that as a really important and valuable part of their role. and giving them the confidence to be able to then have those conversation and share that information in a really unbiased and full kind of to provide that full level of information, so then women can make those decisions.
And the only thing that I wanted to comment was just, I absolutely think it should be on the NIP for older adults, because Helen Marshall's done some fantastic work, and oh my gosh, Helen, fantastic for your oration as well, about recommending an unfunded vaccine. We know that people make assumptions that people can't afford it, people don't bother having the conversation. So when you recommend an unfunded vaccine, the uptake is always really poor. And often people think that if it was an important vaccine, it would be funded. So I think that's the dilemma, and I think if it was just on the NIP, much easier.
That's so true. I know when we're in my practice, I tell my patients, what's funded on the NIP is the bare bones. It's like budget airline, Jetstar. It gets you from A to B, but I try to give you the information so you have the option of choosing the first class experience, and we find very creative ways to fund things. And sometimes, even recently, there was a batch of Beyfortus that was going to expire. I'm fortunate enough to, as I mentioned, to work in Queensland, so we have a very large supply year-round, and we found ourselves with about 10 boxes of Beyfortus that were about to expire. So we had a discussion amongst the practice with how to best use that when our at-risk cohort and the ones that were eligible had already been vaccinated, what to do with that.
So just to pick up the point about the Department of Veteran Affairs, the claim is that veterans should be getting the best treatment. The Department of Veteran Affairs claims that it will provide the best treatment. So referrals to allied health and a whole lot of other programs are actually funded. And one of the good things about the Department of Veteran Affairs is they'll actually, if it's a target recommended, they'll actually fund it. So it's not actually a private vaccine, it's actually like any of their scripts. So if someone's got a DVA card and they meet the eligibility, it's actually a phone call and an authority prescription, which is what we do for all our patients with a lot of drugs. We just get an authority prescription, and it will be either $30 or $7 depending on, or free if they've reached the safety net. So for a veteran, it's a $7 cost because it's prescription, but it just needs a GP. Now, 4 months ago, it used to be the GP had to write to the department to say, this is a vaccine, why don't we have it? And the department wrote back and said, yes, you qualify, and then you had to ring again. But they've actually changed because of the work that we've done through the Immunisation Coalition and the Australian General Practice Network. We've actually got the department to agree that it's a simple, as far as a GP, it's just ringing, getting authority, and it's a prescription, makes it available. And I think because it's now from 50 onwards, if the person qualifies and it's a target recommended, then it's just a matter of getting an authority prescription for all veterans. So it's important to look at other sources, make sure if there is funding, and some of the private funds will do it, and some places will do it, but I think it's important to actually have the conversation and then get it funded or get it in arms as quickly as you can.
I think my mum made money off of it. My sister helped her claim the $300 or so back. So not only did she not have to pay for it, she made $300 out of getting her RSV vaccine. Really interesting, when we go through advanced health directives in general practice, what we hear, over and over again is that death is not the worst thing that can happen to you. It's that loss of independence, the loss of being able to live in your own home, the indignity of needing help when you never did. You still feel like whatever your date of birth says, you still feel like you're a 20-year-old in the body that you have. And we're having this conversation. Sometimes, with my patients, they're saying it's only $300 compared to the $600 you got me to, pay with the shingles vaccine. And there's also the anti-amyloid medication, the other mAb, that's $40,000 to $80,000. So really, I think, don't make assumptions, have that discussion, but, the choice really should be in our patients' hands. With RSV, I guess working in maternal health, we've got a lot of the grandparents, we've got the parents, we've got the babies. It's really exciting to live in this time where there's active packs of immunisation, the mix of products across all the different age groups. It's very challenging, but I think it's wonderful that we've got this. And I think a lot of us in this room are old enough to remember when rotavirus did not have a vaccine and the impact it made once it was introduced. I remember being so excited to go into a paediatric emergency shift and go, not another oral rehydration patient that's going to sit there for a couple of hours. So I think it will really change things in the next few years. We're looking at a lot of countries that have gone before us, and there's also a lot of countries looking at our program. Any words of wisdom or insights that you'd like to summarise?
I think Rod made this point, and I didn't want to complicate things, but it's clear from the European experience and the Argentinian experience that if this is something that everyone has and everyone knows about it, then it's much more likely to get delivered. And certainly I think some of the figures of coverage of nirsevimab in Chile and Spain was really, this is just something everyone's going to get, and it happened. I think our challenge is to, within what is a complicated program, we have to admit, is to making that everyone's responsibility, is what I always say with immunisation. It's not just the specialists, it's not just the GPs, it's not just the nursing practitioners who specialise in immunisation, it's the midwives, it's the general community. We need to make sure that actually that message is getting out to everyone. And I think the more we can do that for both young children and also older adults, I think the better the benefit will be to Australia. And I think that's, we need to understand the important messages for people, vaccinating mums to protect their babies. We know that's a good message generally. They like to be able to do something to protect their babies. If they haven't had it and the baby's born, they still like to protect their babies. We have good immunisation coverage. And in older people, it's about staying healthy and staying out of the nursing home. And, you know, it'll cost you a lot more if you end up in a private nursing home, you know, that's for sure. So, and maybe we need a bit more of that data in Australia. Maybe that's a call to researchers who work with older adults to maybe look at linked data that can actually demonstrate not only the impact on frailty, but also, you know, late impacts of things like cardiovascular events that occur after RSV infections, similar to flu. You know, it's actually, if you've got coronary artery disease or you've had a mild stroke, maybe you really want to get an RSV vaccine because there is this increased risk of cardiovascular events after being hospitalised with RSV. So there's a lot of health to be gained. So the message for everyone in the room is, and everyone online is, you know, let's all have the same message.
We're coming to the end of the discussion, so I've got one last question from Grant McKenzie online. So while I throw that maybe out to the ether, each of you think about one take-home message that you'd like to share, I guess, with the audience based on our discussions through the day, the past week, and also tonight. The question from Grant is, what are the plans for monitoring viral antigenic variation or mutation to escape neutralisation by monoclonal antibodies? Yes, Peter, thank you.
Okay, so I think Australia, thankfully, is in a very good position. Thanks, Grant, for that question. I'm not sure about the Gambia, where Grant has been doing a lot of his great work. So I think a lot of states are doing sequencing of the virus and also sequencing of wastewater isolates. And we're also involved in WA with a international project of sequencing viruses from countries around the world. And the good news is that so far to date there hasn't been any issues, but we definitely need to do that. And I think Chris Blythe mentioned that actually also sequencing failures of vaccines or immunisation with nirsevimab will be important to that. But we have the technology and it's relatively simple to do. It just costs a little bit of money. So I think about ways to do that.
So Rod, take-home message, I might start over here with you.
I think RSV is something we know more about. It's a good program for children and talk about the common diseases people know, like preventing asthma and bronchiolitis. It's going to be a vaccine that we should consider for adults as well. So it's here, I think it's now something we can do something about. So RSV is now the next one to be. And let's talk about it and let's get everyone aware of it.
I guess my pearl of wisdom would just be specifically for nirsevimab. It's not new. Everybody keeps talking about this new product for infants. We've been doing palivizumab for 20 years at the Children's Hospital in Melbourne, given it to over 2,000 infants, and even in vaccine-hesitant families, they still received palivizumab because it's not a vaccine. So monoclonal antibodies is not new. This is just a new product that gives us 5 months of protection. So we just need to keep talking about that. It's not new.
I am brought back to the image that was shown before around the two different roads that consumer, woman, patient can go down. I've seen it too many times that it's made to feel very hard and burdensome. So I think the easier we can make that road in decision making for people, the ripple effect will be hugely significant.
And I'll just make the point that vaccines and monoclonal antibodies don't save lives and keep children and adults out of hospital. Immunisation does. So let's make sure that whatever we've got in Australia, that we use to the ultimate to make sure that everyone's protected.
And I think it's time, so we'll wrap that up. But more importantly, none of this would happen without everyone in this room and people online, because that's how it gets into the arms. Back to you, Paul Griffin.
Thank you.